This is not an organizational chart, and even though your brains probably told you it was as soon as it came up here, it's just a way of me showing to you different components or parts that go into making CSIC possible. So John mentioned to you that the company that has supported CSIC is a group called Healthcare Environment up in Minnesota. And the solid lines represent to you formal relationships in the company. So formally, we have a team. We'll introduce them to you later, not today. We also formally have a very important thing we call heads, which is the software and the data warehouse that you all have used. And then we formally have created and supported the Caring Science International Collaborative. And formally, Dr. Nelson is the president, but informally, researchers across the globe can decide that they want to participate in this area of research. So you here are all here voluntarily. The other one that we've added to here, and John mentioned them a couple of times this morning, is the content expert partners. And you see that's a dashed line too. So although we refer to them as partners, it doesn't mean that there's a business legal partnership. It simply means that we believe that they have an area of expertise that from our research, especially the past 5 years, has shown there's great need of help in these areas. And in meeting different businesses and finding out that they have an expertise in that area, if we feel that they might be good sources for us to tap into, we've asked them if they would like to be available to be tapped into. And so you're going to meet 2 of them this morning. And for our content expert partners, there are 2. You heard John mention from our past 5 years of study, there are 4 areas that have come to the top that have risen that really need attention around the world. One of them is having caring leadership, leaders that care for me. One is staffing and scheduling. One is the need to be educated. And the other one is we need good data. We need data that helps inform us. So with the great expertise of my IT partner, I would invite Sean Drake and Julie Chisholm to come up, or Julia, and they're going to talk to you about Workforce Edge.
What's the... Okay. Well, I think we'll have to sit too, so I'm going to have a few clicks. My name's Sean Drake, Managing Partner, Workforce Edge. My colleague, Jillian Chisholm, our VP of International Operations. I will be under 10 minutes. And we threw a couple extra slides in here around data, because this is around turning data into operational solutions from our perspective. We've been around for about 23 years. We've worked with organizations, states, provinces, jurisdictions, all levels of government, public-private health systems, between 500 employees to 200,000. And we have a model of health workforce optimization. We're not going to get into all of that today, but that's what we collaboratively work with healthcare organizations in developing. And, we always like to say, we take care of those who care for others, right? And that includes the nursing workforce, but also your allied health, your environmental services, housekeeping, everyone who's really focused on that patient experience. So we all know this story, right? It's difficult to attract and retain. That's why we're all here. There's been a lot of pain compounded in the past few years. These are all things that, from our perspective, if we're not getting the planning, the scheduling, and the deployment of our resources right, that we can't fix. And I was very interested, John, to see some of your data there, looking at causal relationships between scheduling and intent to stay, and overall satisfaction and ability to provide care. It's chaotic. I think culturally, I've been doing this for 20 years. What I've seen in healthcare is it's accepted that scheduling and deployment is hard, that it's chaotic, that it's tough, right? That it's not predictable, that you can change my schedule. You can, I don't need to know when I'm working, right? We have managers who are doing things like building schedules on the weekend, right? We have folks doing real transactional, low value work and repetitive decisions who are not at the point of care. And we load more and more onto the backs of managers every single day, and more onto the backs of nurses and other providers every single day as well. So our model really looks at how do we start to provide services and support systems out to the units, and how do we get this right? Because this is 70% of the budget. This is, this is all of your predictability. You have busy people who really can't manage looking after themselves. Forget self-care. I mean, that's something else which is putting back on everyone again, right? This is really about taking care of the resources, and you can really make your values come alive in an organization through scheduling and deployment. It's a very emotional space. Here's a little bit of data I just pulled out. Now, we had a survey, and it wasn't specific, it wasn't scientific, but it sort of dawned on us. Every time we get into an organization, we do a little pulse survey, right? And we thought, we've been asking different questions in a lot of the organizations, but we actually took a look at, we isolated a few questions where we had asked them, consistently over the past 18 months. And of course, we work across the entire workforce. So we had about 5,000 respondents, and this is really basic stuff, but just to give you a bit of a flavor, right? So how far in advance do you know your schedule? Well, 56% of respondents don't know their schedule more than 4 weeks out. I mean, I don't know how you raise a family and plan your life. How far in advance would you like to know your schedule? Wow. Surprise, 84% of respondents would like to know their schedule more than 4 weeks out, right? And again, this is really simple stuff, but health systems don't do it well. And that's where we come in, right? Notice a schedule change. Well, more than half respondents have their schedule change within 3 days notice or less. So you don't know it for more than a month in advance, and then it changes, on a dime. Notice the shifts offered. Well, what does this one say? How far in advance to get called out? So if I want to work and I'm going to work over my FTE, or I'm a part-time or a casual and I want to pick up 60%, I mean, you're not even offered an additional shift until the day up. And when you look at all of your sick time averages, all of your PTO, your vacation, granted months and months in advance, we're not doing anything about it. We're just letting it be chaotic. Redeployment. When I'm redeployed, I don't really necessarily have all the skills I need to take a full patient assignment and to take care of myself and provide safe care. And after all of this, please, at least can you pay me? Well, 30% say I see pay errors constantly. And when I do catch an error, are they easily identified and resolved? No, almost 60% of respondents say, I don't even know if I'm getting paid right at the end of the day when I have the itch. So, there's a bunch of findings. Again, nothing's a surprise. This is just some data. We did run some regression analysis as well and developed a model around trying to validate our model to say, was it a hunch we developed the model or not? But it really comes down to predictability, right? And providing predictability, providing operating procedures like clinical pathways to managers, to staff in this ecosystem. And, all of this stuff we found are the things that make people leave. And, from a research perspective, we would want to urge this collaborative and community, to try to measure what would be acceptable field-ready solutions, right, for health systems. So when we come along, this is the first thing we do, and we just help you build a roadmap, and we look at all those different elements, and we run the business case, and we put together the integrated plan going forward. There's a lot of internal work and work we can help with, and we've done this work, the provinces, states, all levels of government, massive systems, small systems, and everything from inpatient, acute, community, ambulatory, ambulance, lab, like services, the whole continuum of care, long-term care, aging care as well.